Hello, sisters. Please, can we start with the presentation? Hello.
Hi.
Please, let's start with the presentation.
Good afternoon, class. Please, we are Group 10 and we are presenting on uterine inversion. It's our expectation that the student midwife will be able to define uterine inversion, explain the various classes of uterine inversion, state the causes and risk factors of uterine inversion, identify the signs and symptoms of uterine inversion, and be able to discuss the various managements of uterine inversion. Next slide, please. So, uterine inversion is a rare but life-threatening obstetric emergency where the uterus turns partially or completely inside out, usually following childbirth. The uterine fundus collapse through the cervix into or through the vaginal cavity. It is often associated with profound hemorrhage and then shock. Classification of uterine inversion. It can be classified into two groups. We have the degree classification and then timing classification. So let's begin with the classification by degree. One, we have the first degree, also known as incomplete inversion. With this type, the uterine fundus inverts but do not protrude through the cervix. It will remain within the uterine cavity. We also have the second, third, and fourth degree. So with the second degree, it's also known as the complete inversion, whereby the uterine fundus will protrude through the cervix into the vagina. We also have the third degree, known as the prolapse, whereby the inverted uterus will protrude outside the vulva so it can be seen. And then lastly, we have the fourth degree, known as the total inversion, whereby the entire uterus, including the cervix, will invert and then is found outside the vulva. But we say this one is normally rare. It's very rare and is often accompanied by vaginal inversion. Let's move on to the other classification. That's the classification by timing. We have the acute, subacute, and chronic. With the acute inversion, it occurs within 24 hours of delivery and is the most commonest. We also have subacute, which occurs after 24 hours and within a period of 4 weeks after postpartum. We also have the chronic inversion, which occurs after 4 weeks of postpartum, which is very rare. Causes and risk factors. Next slide, please. So we say with the causes of uterine inversion, it's multifactorial in the sense that it's mostly related to medical intervention that will lead to the inversion. So number one on the list, we have excessive traction on the umbilical cord. This is when, especially when the placenta implantation is at the fundal portion of the uterus. So, this is when it normally occurs during when the placenta implantation is at the fundus, and also in cases of uterine atony. So with the little traction on the cord, you will see the fundal portion also following, leading to an indentation caused by the little pressure you applied on the cord. We also have fundal pressure. We've been advised that it's archaic. We should stop practicing, but some midwives have been practicing it. We say it's an inappropriate way of conducting delivery. So as you apply pressure onto the fundus during delivery or during placental delivery, the uterine fundus can invert together with the delivery process. We also have uterine atony. In cases where the uterus is unable to contract on its own, for retraction to take place, for delivery process to be smooth, and also placenta delivery to be smooth, you will it can lead to uterine inversion. Sorry. We also have abnormal placental adhesion in cases of placenta percreta and accreta in the rest. Since the implantation has gone beyond the endometrial lining, the the as you pull the cord, it is very likely that the uterine fundus and the entire uterus can come together with the placental delivery. We also have short umbilical cord, and especially when the cord or the placenta is being situated at the fundal area. And we all know that with descent and delivery, as the baby descends, the cord will also descend with the baby, and the cord isn't elastic for it to be capable of stretching. So when the cord is shorter than normal, as the baby descends, there's a little pressure already on the cord to the placental area. So when care is not taken, as you pull the placenta out, it can also pull the fundus with it, causing an inversion. We also have precipitate labor. Since everything with precipitate labor is abnormal, you see the contractions increasing or abnormally increasing than the normal way, and everything uh, becoming excessive. So as the baby comes out excessively with increasing contractions and all the abnormal process, the uterine fundus too can come along with the baby, and then there will be an indentation at the fundal portion. Signs and symptoms. We say the classic presentation is a combination of hemorrhage, pain, and shock, often disproportionate to blood loss. There's normally vaginal bleeding during uterine inversion. And secondly, we have bradycardia. As the heart pumps blood and the blood is keeping the blood vessels out, there will be increase in workload of the heart. So initially there will be tachycardia, and as the heart increases its workload, trying to compensate the various organs within the system, and yet still venous return is poor, it then becomes tired, leading to bradycardia. And then also, we all know that shock is associated with excessive sweating. And then with uterine inversions, since there will be pain due to excessive pull on other structures, whilst the uterus pull out, it pulls along with other structures. So there could be pain. And so the body tries to compensate with excessive sweating. Then hypotension in the sense that the blood has been escaping out, and so pressure within the blood vessels will be reduced, leading to hypotension. Also, severe lower abdominal pain, and then palpable mass as the uterus inverts. When you are to conduct vaginal examination, or when you are trying to assess the woman, you will find a palpable mass within the vagina. Inability to palpate the uterine fundus. The fundus itself has inverts, and so if you try to palpate it abdominally, definitely you will not find anything there. And then all these signs and symptoms will then lead to the woman getting into shock. Management of uterine inversion. In every obstetric emergency, we say that when you are managing it, you should call for help, since you cannot do it all by yourself. Then also, you conduct your immediate assessment. That's the airway, breathing, and circulation assessment. Then you assess IV line using a large bore cannula for fluid resuscitation. You will be administering crystalloids to correct the fluid loss. So you must use a large bore hole cannula to assess the IV. Then you stop all uterotonics. The The uterus is now out, so there's no need for administering uterotonics. You will have to relax the uterus to replace it back before you can administer uterotonics. So you stop all uterotonics immediately. Then you also use uterine relaxant. That's the tocolytics, the terbutaline, the nitroglycerin, and also we use Maxoff for relaxing the cervical ring sometimes. So any tocolytics that you find available, you can use it in the aim of relaxing the uterus. Next slide. With the management of uterine inversion, we have the non-surgical management and then the surgical management. So with the non-surgical management, we have the Johnson's maneuver. And then with the Johnson's maneuver, we call it the manual replacement of the uterus. So you place your hand inside the vagina with your palm touching the fundus. We tried to get the video, but all we saw was lecturing and pictures. So let's manage the pictures we have there. And then with the uterine fundus touching your palm, you try to push it back with your fingers, navigating through the cervical constriction ring. And then you push the uterus in a steady motion, but with a little pressure, aiming towards the maddest umbilicus. So when the uterus is now being replaced, we call something holding step. You make a fist inside the uterus to wait for the uterus to contract firmly on its own. Then you get to know the uterus is back. Then you take your hand out. So when the Johnson's maneuver fails, we then try the hydrostatic O'Sullivan method. And then with this one, we use warm normal saline. Then you put the normal saline into the vagina to help it distend the vagina. And as it distends the vagina, we have the notion, or we have the belief that it is going to push the uterus back to its position. And then as it pushes it back to its position, the inverted portion of the fundus will come out through the cervix. We also have the surgical management. We have number one on the list is the Huntington's maneuver. With the Huntington's maneuver, it's done at the theater. It's a surgical procedure, so we don't do it at the labor ward. It's done at the theater. So here, the surgeon will make an incision through the abdomen to gain access to the pelvic cavity. And then with the use of an Alice forceps, we know that on top of the uterus is the round ligaments. So where as they incise and get into the pelvic cavity, they will get to know the indentation of the uterus. And as they get to know as they locate where the indentation has taken place, they use the Alice forceps to pull the round ligaments at where the indentation has taken place and pull it up. As they pull the ligaments up, the indented portion will also come out. So that is the Huntington maneuver. But when all these maneuvers fails, we will have no other option than to cancel the mother and then gain an informed consent to take the uterus out, which is the hysterectomy. So after a successful replacement, you will have to administer uterotonics. That's the oxytocin or the ergots to help contract the uterus. And also, antibiotics are administered since during the process of manual replacement, definitely you will pick some of the commensals of the vagina to the uterus. And when who is this? And when they get into the uterus, definitely since it's not their normal position or they are not the normal flora of the uterus, they will definitely cause harm there. And so antibiotics have to be administered to combat any infection. Manual assessments of the uterus too should be done after the replacement to rule out trauma or retained products. I forgot to say this. When your manual replacement is successful and then you have the placenta in situ, you will have to conduct a manual removal of the placenta. You cannot pull the cord out since there could be a reinversion again. Complications of uterine inversion. One, we have hemorrhagic shock. We say with uterine inversion, one sign is visible vaginal bleeding. So as the mother bleeds and interventions delay, definitely the woman will enter into shock, and the diagnosis of this shock will be hemorrhagic shock. Also, neurogenic shock can also take place since there are many nerves supplied to the uterus. So when the uterus pulls out together with its other structures, definitely it will affect the nerve return and nerve supply to leading to neurogenic shock. We then have DIC. DIC in the sense that when there is inversion, the woman will be bleeding and enter into hemorrhagic shock. When hemorrhagic shock occurs, since the heart in its own way will shunt blood supply to other organs. We learned this in pathology, if you all can remember. When the blood is being shunted to other organs, it will remain only the heart and the brain that the heart will try to compensate, and by so doing there will be acidosis in other tissues, so it will kill the platelet factor within the other tissues, and so platelet factor has already been reduced, and as the woman continues to bleed too, it's the platelet factor are being escaping out, it's being escaped out. Sorry. And also I have forgotten the name, but the body will try to release some substances which will cause blood clots within the smaller vessels within the mother's system, and by so doing blood clot is being formed within the vessels, yet the remaining platelets within the tissues are malfunctioned by the acidosis, and so platelet factor will be lost and continuous bleeding will take place with clot formation in other tiny arteries. This is called the DIC. We also have endometriosis. When infection is not being treated properly, since during manual replacement or the surgical procedure, certain bacteria has been introduced to places where they are not supposed to be. And so when antibiotics are not administered correctly, definitely endometriosis will occur. And as the uterus inverts to blood supply can be cut off when interventions delay. So when interventions delays and blood supply cuts off to the uterus will be necrosed, leading to uterine necrosis. Lastly, we have the Sheehan syndrome. Sheehan syndrome is associated with the pituitary gland. We all know that the pituitary gland enlarges during pregnancy. So now that the woman has delivered and the pituitary gland is still enlarged, its blood consumption and oxygen consumption has also increased. So in cases of uterine inversion and there's chance of blood to certain organs, the pituitary gland is affected, and if there's no blood supply to it, it will become necrosed, leading to the Sheehan syndrome. Next slide. Prevention of uterine inversion. One, we have avoid fundal pressure. Two, you wait for a strong uterine contraction before pulling on the cord. You don't deliver the cord immediately after the baby is out. You wait. You put your hand on the uterus to feel a strong uterine contraction before you carry on with the other process. Thirdly, we have deliver the cord by control cord traction. Then lastly, in the presence of uterine atony, you employ interventions in solving it before attempting to deliver placenta. If not, the fundal portion will invert together with the placenta. Thank you. These are our reference. Please, a sister there. Please, we are done.
All right, please, any questions for them? Hello. Hi. Please, any question for them? All right, then let's move to the next group. Group 11. Group 10, thank you. Group 11. Sisters, please, let's try and ask them questions. Thank you.
Good afternoon, sisters.
I'll try. Afternoon.
Please, we are Group 11. I'm Sarah Mensah. I'm presenting on behalf of Group 11. And our topic is uterine prolapse. Please, next slide. Please, these are our content: introduction, definition, causes, types of prolapse, degree of prolapse, diagnosis and investigation, signs and symptoms, complications and management. So, introduction. Uterine prolapse is one of the common clinical conditions met in day-to-day gynecological practice. It is most often seen in multiparous women, and it is a form of herniation. So uterine prolapse can happen to women of any age, but it affects postmenopausal women who had one or more vaginal deliveries. And the incidence of prolapse is about 1 in 250 pregnancies. So please, uterine prolapse, as we all heard of it before, or as we all know uterine prolapse. Uterine prolapse is when the uterus moves from its original state to a different position, or when there is a herniation of the uterus. That is uterine prolapse. Uterine prolapse occurs when pelvic floor muscles and ligaments stretch and weaken, providing inadequate support for the uterus. So the uterus then slips down into or protrudes out of the vagina. So weakening of the pelvic muscles that leads to uterine prolapse can be caused by damage to supportive tissues during pregnancy and childbirth, effects of gravity, loss of estrogen. So uterine prolapse, as I earlier explained, when the ligament supporting the uterus becomes weakened, then the uterus tries to protrude down into the vagina or out of the vagina into the cervix or out of the cervix and other stuffs. Yeah. So that's uterine prolapse. When the muscles around the uterus or muscles supporting the uterus becomes weakened. And it can be caused by damage to supportive tissues. When the round ligament, the broad ligament, and other tissues becomes damaged, the uterus no longer receives that support or that support from the other ligament, then it tries to sink down or protrudes. And two is effect of gravity. It's effect of gravity in the extent that when during second stage of labor, when we try to give fundal pressure, it can affect the supporting ligament, which then can cause uterine prolapse. Or when during heavy lifting, it is also in a form of gravity we putting on the surrounding organs or surrounding ligaments. So when we lift heavy objects, it can put strain on the ligaments, thereby causing uterine prolapse, or when the baby in the fetus in the mother is big, when there is macrosomia, it can cause pressure or put pressure on the uterus. That is causing uterine prolapse. So that is the explanation to the effect of gravity. And also loss of estrogen. Earlier on, we said that it's mostly found in menopausal women or postmenopausal women or women who are multiparous. So during the postmenopausal women, their stage, there is less estrogen, and the estrogen strengthens the ligaments and the um, uh, ligaments and the supporting structures around the uterus. So when there is decrease in estrogen, it means that the ligaments around the uterus also becomes weakened and thereby causes uterine prolapse. Okay. So these are the supporting ligaments and muscles. We have the round ligament, we have the broad ligament, we have the pubocervical ligament, we have the pelvic floor muscles, we have the uterosacral ligaments. Next slide. Okay. So please, this is a picture of uterine prolapse. This is a normal uterine prolapse. The left side is the normal uterus, normal situation of the uterus, and the right side is the prolapse of the uterus. The uterus is trying to come down. That is the uterine prolapse. Causes of uterine prolapse. We have multiple vaginal delivery. That's the excessive stretching of the pelvic floor muscles and ligaments that occur during childbirth, because overstretching causes atonicity, whereas torn muscles could be stretched or torn up. So when there is multiple vaginal delivery, it can cause pressure because once you give birth, you don't rest. Then even if you rest within intervals, once the babies are many, all of the fetuses are putting pressure on the ligaments. So it becomes weakened, and then later on causes uterine prolapse. And aside that, the uterus also becomes atonic. It becomes tired because of the number of pregnancies or the number of childbirth it has been carrying. So it becomes tired and thereby causes uterine prolapse. And when there is pressure on the peripheral nerve injury, when the peripheral nerves becomes injured, when there is pressure on the peripheral nerves, it can also cause uterine prolapse, because the pudendal nerve injury during childbirth causes prolapse, which is reversible in 60%, and it may be responsible for stress incontinence also. Please, next slide. So bearing down, prolonged bearing down. So before full dilatation of the cervix and when the bladder is not emptied. So before full dilatation of the cervix, if the bladder is full, we have to empty the bladder before the baby comes or before the woman bears down. So if the bladder is full and the bladder is not emptied, when the woman bears down, the baby puts pressure on the bladder and thereby causing damages. And when the bladder too is damaged, the supporting ligaments too will be affected, and due to that, it will cause uterine prolapse. Lifting of heavy objects, as I earlier explained. So when we lift heavy objects just after delivery without any rest or pelvic floor exercises, it weakens the muscles and the ligaments, thereby causes uterine prolapse. And delivery of big baby also stresses the perineal muscles that lead to prolapse. Precipitate labor and fundal pressure may be responsible for prolapse. So when labor is precipitated or when it's faster than its normal duration, it can cause prolonged uterine prolapse. And also with the fundal pressure, I think we've stopped the fundal pressure now, since we all know the complications associated with fundal pressure. When we give the fundal pressure, it affects the other ligaments and other muscles supporting the uterus, and due to that, it will cause uterine prolapse. Sorry, please, can you hear me? My network took me off.
I can hear you.
Hello.
Yeah, we can hear you now.
You now.
Hello. Please, I'm Prudence, and I'm going to continue from where my sister have already stopped. So I'll continue with the causes of uterine prolapse. Please, can you hear me?
Yes, we
Yes.
can.
Okay. So the next one is aging. And as one's age, as a woman age, it also reduces the elasticity of these pelvic ligaments. And because there is reduction in the elasticity, it causes the uterus to sink down, leading to uterine prolapse. Also, we have congenital weaknesses. And with this congenital weakness, some women are born with weak connective tissues. And because their connective tissues are already weak from birth, it cannot support the uterus. It leads to what? Uterine prolapse. Also, we have the pelvic mass or tumor. Tumors such as fibroid. We know that some fibroids are so huge that they causes pressure on this uterus. And as they causes pressure to the uterus, it causes the ligaments holding the uterus in place to become weak. And as it gets weak, then it causes the uterus to sink down into the vagina. Also, effects of gravity, which my sister have explained earlier on. So as a woman, when you carry heavy loads or you like lifting heavy objects, it puts pressure on your pelvic organs, including your uterus. And because there is pressure there, it also weakens the pelvic ligaments, leading to uterine prolapse. So this is the image of a normal uterus, which is in place. The retroverted one and then the anteverted one. So we have types of prolapse. So we are dealing with the uterine prolapse. But aside uterine prolapse, we also have other types of prolapse, which are the cystocele. And with the cystocele, this is when the wall between the bladder and the vagina gets weakened. And because it's weak, it causes the bladder to bulge into the front part of the vagina, causing cystocele. And some of the signs of cystocele are you have urinary issues such as frequency or urgency, and also you have stress incontinence. So these are types of prolapse, but not uterine prolapse. Uterine prolapse is also part of types of prolapse. So with the rectocele, this happens when the wall between the rectum and the vagina gets weakened. And when it gets weakened, it causes the rectum rather to bulge into the vagina. and that will be termed as rectal cell. And some of the signs of rectal cell too are there will be bowel movement difficulty. So you have difficulty with bowel movement, and also you feel that after going to private, you still feel that your rectum isn't emptied. It's not fully emptied. We also have the enterocolon. This one, it is when the small intestine pushes down between the uterus and the rectum into the vaginal canal, and that one is the most common in individuals who have previously had a hysterectomy. So these are the types of prolapse. So if you look at the second, so the first image is showing the normal placement of your uterus, where the arrow is showing. If you look at the cursor, where the cursor is, that is the normal placement of the uterus, the bladder, and the rectum. So the second image, where we have the bladder prolapse, so you see that if you look at the normal one, in this case, you see that the bladder has prolapsed. It has gone down, causing bladder prolapse, which is the cystosome. And with the third image, which is the prolapsed rectosome, with that one, you see that the rectum have prolapsed into the vagina. Then our final one is the uterine prolapse, which is the uterus passing through the vagina or descending into the vagina. So these are pictures of the enteral cell, which is the small intestines, and then that of the rectal cell. So we have degrees of prolapse. This one is degrees of uterine prolapse. So we are back to the uterine prolapse. So these are the degrees of uterine prolapse. We have the first degree. With the first degree, the uterus descends from its anatomical position. But in this case, the external os remains inside the vagina. So this one, the cervix, will go into the vagina. And with the second one, the external os protrudes outside the vagina, which means that the whole of the cervix gets into the vagina. Unlike the first one, the external os is still up, but with this one, the external os gets out of the vagina, but the uterine body still remains inside the vagina. So with the first degree, the cervix is inside the vagina, but it's not out. With the second degree, the cervix is down out of the vagina, but the body of the uterus is still up. And with the third degree, the uterine cervix and the body descends. The uterine cervix and the body descends to lie outside the enteritis, and it's termed the procedentia. So with this one, the cervix and the body all will go out of the vagina, and this is what is called the third degree or the procedentia, and that is the severest form of what? The degrees of uterine prolapse. So the prolapse of the uterus with eversion of the entire vagina, it is inevitably associated with cystocele and then enteral cell. So these are the classifications. So the first picture is the normal one, the normal uterus. That's the level it stands. And the second one, which is into the vagina, not like the normal one. So you see the external os. the internal and external os, they are into the vagina. Unlike the first one, you realize that the internal os is up, but because this one there is a descent, the uterus have descended into the vagina. You realize that the internal os is also inside the vagina. And so with the second one, you also realize that in this case, the cervix have reached the level of the vagina, which means that the moment you put your hand, that's what you will be touching. So there's both internal and external os are inside the vagina. Even some part of this have come down. And the third degree, you also realize that with the third degree, the cervix, the whole of the cervix and part of the uterus to have gotten into the vagina. And it's even out of the vagina. In this case, it's out of the vagina. And with the procedentia, which is the last one and the severest form of it, the whole uterus, aside the fundus, is out of the what? The vagina. So you can visibly see it. Please, next slide. So these are the types of uterine prolapse. So the second image, you see that it has gone down, and then with the last image to it, that's just the whole of the uterus is out of the vagina. So we have already talked about it. So these are still the degrees of uterine prolapse. So we'll go to investigations. With the investigations, you will do hematology to know the HB level of the client. In case you are coming to do any operation, you need to know the HB level, the platelets level, and other. You check the neutrophils and other labs to be sure that there is bacterial infections aside the prolapse and those things. You also do rectal scan. When you do this rectal scan, then you'll be able to rule out other diagnoses like rectal cell. And also you do pelvic scan. This pelvic scan will help you to know. Maybe it might still be in the first stage and you might not know. So when you first degree rather, so when you do the scan, you will know the stage at which the uterine prolapse is at, and also to rule out other differential diagnoses like rectal cell, cystal cell, and enteral cell. Then you can also do, then you'll be able to see that the cervix have descended down into the vagina or so close into the vagina. Or when you use speculum and examine the vagina, you realize that the cervix have gone down into the vagina or even coming out of the vagina. Then you can also do X-ray or magnetic resonance imaging to rule out uterine prolapse. Next slide, please. So the differential diagnosis. So you need to be sure that you are dealing with uterine prolapse so that you wouldn't be treating you might be mistaking a different diagnosis as uterine prolapse and managing uterine prolapse, which is not the case. So some of the differential diagnoses are cystic swelling in the vagina. Then you also have chronic inversion of the uterus. So it can either be an inverted uterus, but because maybe you didn't do your examination well, then you misdiagnose as uterine prolapse. Then you also have hypertrophy of the cervix, where the cervix have increased in size, but because you didn't check well, you might think that it has descended into the vagina. Then you also have all other causes of low back pain and urinary system. and urinary symptoms. Then we have vaginitis, and here today is congestion of the vagina, and because with uterine prolapse, you might mistake vaginitis for uterine prolapse. So with the signs of uterine prolapse, we have it may be visible on vaginal inspection. In the case that it is at the third stage, when you are doing inspection at the vulva, you realize that the cervix is at the vulva, and this will tell you that there is uterine prolapse. In the cases of minor prolapse, it may be visible on straining. So this one, when the woman is straining, so if the woman is straining and you are examining the woman, you realize that there is a prolapse, uterine prolapse as such. Then also rectal examination also differentiate between rectal cell and enteral cell. So when you do rectal examination, then you'll be able to know that it is either rectal cell or enteral cell, but not uterine prolapse. So the symptoms. So in this case, the woman will complain of feeling something coming down per her vagina, and also discomfort walking. So when there is a uterine prolapse, because the uterus is inside the vagina, the woman will feel that there is something inside the vagina. And also when she's walking, she will feel uncomfortable walking. And also there will be backache, and also dragging pain in the pelvis. This is because all these ligaments are pulled, and because it is pulling, it's also attached to nerve endings, and this will cause pain at the back of the woman. There will also be dyspareunia, which is painful sex, because already the cervix has descended into the vagina. So if in the case that is a first degree, the woman might not know. So this woman will complain to you that she always have pain during sex. We also have urinary symptoms. So with the urinary symptoms, it can also be present in cystocele. So if a woman also complains of urinary symptoms, you should not just conclude that it is uterine prolapse, but you need to rule out. There might be difficulty passing stool because the uterus has descended down, and we all know that the uterus is in between the bladder and that of the uterus. And here is a case that the body of the uterus has descended down. And if it has descended down, it means that it will be blocking or it will be putting pressure on the rectum. And because it's putting pressure on the rectum, it will definitely cause discomfort or even difficulty when this woman is passing urine or stool. So there will be incomplete evacuation, which will lead to frequent desire to pass urine. Also, there will be urgency and frequency of maturation. This can also be due to cystitis. So as I said earlier on, some of the symptoms, when you see them, you need to also rule out other differential diagnosis, but not be conclusive. We also have painful maturation, which can also be due to infection. Then stress incontinence is also associated with urethral, then retention of urine. So we have complications of uterine prolapse. So complications of uterine prolapse, we have urine retention. Urine retention in the sense that since the body of the uterus has descended, it will be blocking the urethra, which will lead to urine retention, because when the urine is coming, even though the internal walls of the urethra might be open, but because of the blockage from the uterus side, it will cause the urine to retain. And also it can cause ulcers. And with the ulcers too, because there is force, the uterus is not at its right place. And so as it's descending, it can either cause some ulcers at the bladder side or even at the rectum side. which at the end of it all might even result in these rectal cells and cysto cells. Fistulas like vaginal fistulas. And also, we also have infections such as, so these are all complications. So infections such as endometritis, which is infection in the endometrium. And then we have the pyelonephritis because there is the pulling down of these ligaments, and then the nephrons too will be affected because there is a connection between the uterus and that of the bladder. And we have cystitis, salpingitis, because the salpinges have been pulled down, and then also it will also cause the salpingitis. Then we have prolapse of other organs can also, so because of the prolapse of the uterus, it can also cause prolapse of the other organs like that of the bladder and then the rectum. These are all complications. We can also have bowel discomfort and chronic constipation because the uterus is blocking the rectum. So with the management, so under the management of uterine prolapse, we have the prevention methods, we have physiotherapy. So under the prevention method, we have a lot of things you are supposed to do, which are these ones. So we have repeat vaginal birth with short interval can cause uterine prolapse. So we will always encourage women to also delay their birth by introducing them to family planning methods to help them space their children, because the quicker they get pregnant, then the uterus is unable to rest. And because it's unable to rest, and these ligaments have been strained for a while, and it has not gone back to its normal state, and then another pregnancy has come, which will cause heavy load on the uterus again, it will lead to, so we encourage women to always take other family planning methods to space their children and then allow the uterus to rest. And also in the first stage, when we are talking about the prevention in the first stage, we will always encourage the women to avoid bearing down when they are not full, because we all realize that most women in their first stage of labor, they wouldn't be full, but because they feel the pain, they try to push the baby out at all costs. And because of that, they will be straining these ligaments. So we also encourage breech delivery and forceps delivery should be done before should be done after full dilatation of the cervix, but not before full dilatation. Because if you do it before full dilatation of the cervix, it can also lead to this uterine prolapse. And also in the second stage, we also avoid prolongation of this stage. So in the second stage, as a midwife, you should be able to hasten the second stage and not delay. When you realize that the perineum is so tight and this baby cannot come out, you give your episiotomy to enlarge the outlet to let this baby come out. But episiotomy should not be a routine, but should be performed when necessary, so that the second stage can be shortened to avoid straining these ligaments. Next slide, please. Please, next slide. So at the third stage, we need to avoid Prader's method. And this Prader method is when, sometimes after delivering the baby, we realize that this woman is bleeding. Then we want to see that, okay, maybe bladder is full. So with this Prader's method, it's like you are massaging the uterus around the bladder side so that the woman can empty the bladder on her own. So in this case, we are going to avoid it. How are we going to avoid it? By passing catheter, urethral catheter, so that we can drain the urine, but not trying to massage the bladder to let the woman void herself. So episiotomy or tear should be carefully sutured. So if you have given episiotomy in your second stage to speed up the delivery, then you should suture it very well so that there will not be spaces to cause any descent of this uterus in the case that the uterus, the ligaments are not recovered and is trying to descend. And during puerperium, you should treat chronic cough and constipation because when a woman is having chronic cough, it will cause pressure at the lower abdominal muscles. And because there is pressure there, it will also cause pressure on the uterus and thereby affecting the ligaments. And at the end of it all leads to uterine prolapse. So if a woman is having chronic cough during puerperium, it is right that we treat it. Avoid strenuous exercise and standing for prolonged period of time. So as the woman is going home, to prevent uterine prolapse, you need to educate them so that they wouldn't go home and be doing strenuous exercises and be standing for long. Because some of them, when they get home, due to the work they are doing, they don't want to relax a little. They just want to go home and continue with what they were doing. Also, we have physiotherapy. So if a uterine prolapse is detected at the early stage, like the first degree, you can help the woman by human with pelvic floor exercises. That is during puerperium and whilst waiting to undergo surgical treatment if it is not resolved. Also, Kegel exercises are also used to tone up the pelvic musculature. So during puerperium, you also encourage the woman to do pelvic Kegel exercises so that the uterus and then the lower abdominal organs can go back to their normal state and get back their tone. So these exercises are done 3 times a day for 20 minutes each. And this one too, it can. So as if the woman cannot go for the 20 minutes, then she can slow it down and move ahead. So maybe 5 minutes, the next day to 10 minutes, and as the woman can endure. So this is the picture of Kegel exercise. So if you want to teach your clients, you can assistant. So we come to the treatment. So with the pessary treatment, it is a mechanical device for correcting and controlling uterine prolapse. So it is a pessary, as the name implies, that is inserted into the vagina so that it will help the uterus to go back. But the pessary does not cure the uterine prolapse. It only holds the genital tract in position. You should know that. So that where it has reached, it wouldn't go down. So you also advise the patient not to undergo. So you advise for patients who cannot undergo surgery, the types of, so people that cannot undergo surgery or they don't want the surgery, then you encourage them to go with the ring pessary and then that of the harsh pessary. So these are all pessaries to put the cervix or wherever the prolapse have reached in place so that it wouldn't continue. Then indications. So during pregnancy, that's first trimester. So during pregnancy, if there is a prolapse, then in that case you use the pessary. And then during puerperium too, you can use the pessary, but if it's unresolved, then you go in for the surgery. But if the client is unfit, that's if the client is unfit for the treatment. But this is still the client's choice. If the patient decides on any method, then you give to the client. If it's pessary method, then you go. But if it has reached the later stage like presidential, that one you will need to go in for surgery. But maybe the first degree and second degree, then you can manage with the pessary. Next slide, please. So management. There's a choice of pessary to be used. The ring pessary is the commonly used one. And the size depends on the size of the vagina. So we have different types, the different sizes, they're in different sizes. And so you will choose the size with the size of the vagina. And also we have sterilization. You make sure that when you are inserting this pessary, which is the ring pessary, you need to make sure that you are using the aseptic techniques in inserting so that you wouldn't introduce other microorganisms into the vagina through to the uterus. So before inserting the pessary, it is kept in a hot water for a few minutes so the pessary can become soft and easy to insert. Then you let this woman come for follow-up. The pessary should be removed, cleaned, and reinserted at regular interval of 6 to 12 months. So the woman will always come. When you insert this vaginal pessary, then you encourage the woman to come for a review at a regular interval so that you can remove it and clean it and reinsert it back. So these are the pessaries. So we have the Gellhorn pessary and then we have the donut pessary, which is the ring pessary that can be used. And this is how it is inserted. So you put it in place so that it will prevent the uterus from sinking down into the vagina. So we have the surgical treatment. We have the reconstructive surgery. So with this one, it's the most common approach, and the goal is to restore the pelvic organs to their natural position while maintaining vaginal function. So this one, with the reconstructive one, it is done on the ligament. So they try to resize the ligaments and put them in their right places so that once the ligaments are reconstructed to their normal position, automatically it pulls the uterus up. Then we have the uteropexy or uterine suspension method. And with this one, the surgeon hinges the uterus back into the original position using your own ligaments or synthetic mesh. This is an option for those who wish to avoid hysterectomy. So in this case, maybe the person doesn't want to undergo hysterectomy. So if the person's own ligaments cannot help, then they'll also use a mesh. And this mesh will help suspend the uterus to its right position so that hysterectomy wouldn't be done on her. Also, we have hysterectomy in many cases. So in this case, if you have the prudential degree or that of the third degree, when nothing can be done, or if all options fail, if you do the pessary method, you do the suspension and all those ones and it fails, then the last option is to do hysterectomy, where there is a total removal of the uterus so that this woman can find herself and also be able to relax herself. So we also have the sacrocolpopexy method. And in this one, it is considered the gold standard for long-term results. The surgeon uses a piece of surgical mesh to attach the top of the vagina or the cervix to the sacrum, the bone at the base of the spine. So in this case, there is a mesh. This method is called the golden standard, and then with this one, the surgeon will use a mesh and hold the top of the vagina or the cervix to the cecum. And the moment the surgeon is able to do that, because if the vagina or the cervix is held to the cecum, which means it cannot move down. And if it cannot move down, automatically the uterus cannot also move down. So we also have the obliterative surgery or colpoclesis. This is the more specialized procedure, usually reserved for individuals who are no longer sexually active and may have health conditions that make longer reconstructive surgery risky. So with this procedure, the surgeon narrows or closes part or all the vaginal canal to avoid a solid or shelf that prevents the organ from dropping down. So this one is meant for women that maybe the persons are no longer interested in anything like sexual intercourse. So in this case, the vaginal canal can be closed or part of it will be closed. And if part of the vagina is closed, which means that the cervix cannot move down. And if it cannot move down, then it will suspend the uterus up there. Next slide, please. So these are our references. Thank you. If there is any question, you can ask. Thank you for your attention.
Well done, sisters. Please, any questions for them? Hello. Hello.
Hello, no question. They did very well for the
All right.
presentation.
All right. The next group, group 12. Someone is saying she's having a question. Alice, you too. Please ask your question. Alice, you too. Unmute yourself and ask your question. Group 12.
Good afternoon, sisters. Please, we are group 12 and we are presenting on cord prolapse and cord presentation. Cord prolapse refers to the occurrence of the cord in front of the presenting part of the fetus when membranes are ruptured. When membranes are ruptured, let's take note of that. The cord is out when membranes are ruptured. And when we talk about cord presentation, for that one, membranes are intact. But when you do VE, you can still feel the cord being in front of the presenting part. So the difference is in cord presentation, membranes are intact. In cord prolapse, membranes have ruptured. We have types of cord prolapse, which is the occult and then the ovate. In the occult cord prolapse, the umbilical cord descends alongside the presenting part, but not beyond it. So you will see that the cord is not ahead of the presenting part. It comes alongside the presenting part. And then when you look at the ovate cord prolapse, the umbilical cord descends past the presenting part and is lower than the presenting part in the pelvis. So that one, the cord will be leading the presenting part, be it breech or the head, whichever part is presenting, the cord will lead it. So in the occult, it comes alongside the presenting part, and then in the ovate, it leads, the cord leads the presenting part. Here are some risk factors for cord prolapse. We have unstable lie. This is where the presentation of the fetus keeps changing. One time you will take the scan, it is breech. Another time you will go, it's transverse. The next day it is oblique. And mostly when the mother is more than 37 weeks of gestation, and then she's having such unstable lie, we have to consider admitting the woman until she delivers to avoid the risk of cord prolapse. We also have breech presentation, especially in footling breech. The cord can easily slip between and then pass the fetal feet and into the pelvis. It can happen in any type of breech, but it is mostly common in the footling breech. Then we have prematurity. Because of the smaller size of the fetus in relation to the uterus, it allows the cord to prolapse because the baby is small. So it will allow the cord to prolapse. Then we have polyhydramnios, excessive amount of fluid around the fetus. The cord is liable to be swept down in a gush of liquor if membrane ruptures spontaneously. So that is why mostly when the woman reports that even if she's on admission and then she comes that her membranes have ruptured, you have to rule out cord prolapse so that any necessary actions can be taken. So you do vaginal examination to rule out cord prolapse. Then we have artificial rupture of membranes, particularly when the presenting part of the fetus is high in the pelvis. So you'll see that when the presenting part is high, you do VE, you realize that membranes are bulging, but you cannot feel the presenting part. It is advised not to rupture membranes, not to rupture the membrane. So you have to wait and see if the head will descend. If you are not feeling the descent, don't rupture. So controlled release of the liquor, even when the descent is there, and then you are rupturing the membranes, you have to control the release of the liquor to prevent prolapse of the cord. Then when the head is high, as I said, in the artificial rupture of membranes, we shouldn't attempt to rupture membranes when the head is high because it will cause prolapse of the cord to occur. So when membranes rupture spontaneously, when the fetal head, please go back. When the fetal head is high, a loop of cord is able to pass between the uterine wall and the fetus, resulting in it lying in front of the presenting part. As the presenting part descends, the cord becomes trapped and occluded. Next, please. So here is the physiology. The umbilical cord prolapse is where the umbilical cord descends through the cervix, as we said earlier. So it's either with or before the presenting part, as we said in the occult, and then the ovates, in the occult and then the ovates. So the umbilical cord is either with the head or before the head in the presenting part of the fetus. Subsequently, fetal hypoxia occurs. So when cord prolapse occurs, fetal hypoxia can occur through mechanisms. One is occlusion, and then two is arterial vasospasm. So when we talk of the occlusion, the presenting part of the fetus presses on the umbilical cord, occluding blood flow to the fetus, especially the one that comes along with the fetal head, not the one that leads, which is the occult. So the head will press on, or the presenting part will press on the cord, which will cut off blood supply to the fetus. And then we also have the arterial vasospasm. The exposure of the umbilical cord to the outside environment, to the cold atmosphere, results in umbilical arterial vasospasm, which reduces the blood flow to the fetus. This is how we can diagnose cord prolapse or presentation. The cord may be visible outside. As the woman comes and you are examining the woman, you can see the cord visibly at the vulva, or immediately you introduce your hand into the vagina to do examination, you can see it. Or even when you pass speculum, especially for a woman who is not due or who is not viable to deliver, you pass speculum and then you will see the cord prolapsing. Then occult prolapse may be diagnosed when fetal heart rate abnormalities occur, because for that one, it is coming alongside the head. So it might be difficult to rule it out. So you will see that one time you check the FH, so the FHR will be occasionally on and off. And then you can also use a CTG and ultrasound to detect the cord prolapse and then the cord presentation. Complications of cord prolapse, we have fetal hypoxia. So you know that when we said the occlusion, especially when the presenting part is pressing on the cord, it will occlude blood supply to the fetus. So it's definitely hypoxia will occur, and then the baby will have birth asphyxia, and then there will be neurological injury to the baby, and then perinatal mortality. For the mother, the only complication that the mother might face is we have to do emergency surgery. So that is the risk for the mother. So this can be prevented by ultrasound identification of malpresentation. And then we should avoid artificial rupture of membranes when the presenting part is high or when presenting parts have not engaged. And we should also monitor high-risk pregnancies very closely. So to manage this is an obstetric emergency. And in all obstetric emergencies, we call for help. So you first have to call for help. The umbilical cord prolapse is an obstetric emergency and it should be managed as follows. You should avoid handling the cord to reduce the vasospasm that we talked about. Do not handle the cord, do not touch the cord. Then you manually elevate the presenting part by lifting the presenting part off the cord by vaginal digital examination. So you use your 2 fingers to push the head up a little, making sure not to touch the cord. Then alternatively, if you are in the community, like a CHIPS compound, you fill the mother's bladder with about 500 ml of normal saline, preferably warm normal saline through the urinary catheter, and then you arrange for immediate transfer to a hospital, a larger hospital. You encourage left lateral positions whilst you are transferring the woman, or even in your facility as you are managing. You ensure that the woman lies on her left lateral with a head down, pillow placed under left hip or knee, chest position. This will relieve pressure off the cord from the presenting part. So the whole idea is to relieve pressure from the cord, making sure that the presenting part does not occlude the cord and then cut off blood supply to the baby. So here is an image of filling the bladder to push the head up and then relieve pressure off the cord, and then also using your fingers to push the head up and relieve the head off the cord, and then a knee chest position to also relieve the pressure from the cord. Please go back. And then the left lateral position, where the woman have a pillow in between her leg and then the head slightly tilted downwards. Next, please. So you should also consider giving tocolytics, because at this point, we do not want anything that will cause occlusion. So if delivery is not imminent, if the woman is not full, then you give tocolytics to relax the uterus, to stop the uterine contractions. It may be sufficient to allow enough time to transfer the woman to where, maybe if you are in a smaller facility, to transfer the woman to a bigger facility for emergency cesarean section. So you have to consider giving the tocolytics. And then it is particularly useful strategy if there are fetal heart rate abnormalities whilst you prepare for emergency CS. So delivery is usually by emergency cesarean section. If the woman is fully dilated, you can do vaginal delivery. If delivery is imminent, you encourage the woman to push, or you give assisted instrumental delivery. You deliver the woman with instruments if the vaginal is 10 cm dilated and then delivery is imminent. If at threshold for viability, which is 23 weeks or 24 weeks plus, and extreme prematurity, expectant management may be discussed due to significant maternal morbidity with cesarean at this gestation and poor fetal outcome. So when you consider the fact that maybe the baby is not so viable that in your setting the baby can survive, you can discuss the option of either allowing the baby to be terminated or going through the cesarean section. Have to be discussed with the doctors and then the woman as well. So here are some references that we used for our work. Thank you. Please, any questions? Sister, please, we are done.
All right. Please, any questions for them? Florence.
Yes, sister. Please, please, I wanted to ask.
Florence.
Yes, I was talking and I was muted. Please, I wanted to ask, if you are in the facility and a woman in labor walks in, what will be her presenting complaint for you to suspect cord prolapse? Thank you.
Okay, so you see when the cord is prolapsing, she will feel something dropping from the vagina, especially when it is coming out of the introitus or it is being visible at the vulva. She will tell you, I once had a client, she said, Madam, me show one when we examined, it wasn't like that, it was something else. So they will feel the pressure in the vagina. And then you yourself, once you open the woman up and then you want to examine, you will see that it is readily there. If it is not occult, it is overt, you readily see it at the vulva, or immediately you introduce your hand into the vagina, you will see that the cord is there. Or the woman will feel the pressure of the cord coming out.
Okay, thank you.
Can you
Please,
go
we've
to the management?
some questions at the comment sections. So if you can answer them for us.
Can you move your slide to the management? Group 12.
Group 12, sister said move your slides to management.
I said management. You are just rushing me through the slides. Please stick to that slide. Stick to that slide, the one you just skipped. Mm-hmm. Can you teach us how the bladder is inflated? Infiltrated, rather. Not inflated, but infiltrated. Group 12. I hope you can hear me. Oh,
Yes, we can hear you.
okay.
Sister, please, you pass the urinary catheter into the bladder. But this time, instead of draining the urine, you will tie the part where the urine will pass to come out. And then you will fill the bladder with the normal saline. You will connect the normal saline into the catheter. You connect the normal saline into the catheter and then tie where the urine is supposed to pass to come out. That is
Where
what.
does the urine pass? Where does the urine pass, and where will your water also pass?
Sister, so where the urine pass is where you fill the bladder with the fluid.
But you are telling us that we will block it, so I'm here confused.
No, so after filling, instead of the fluid coming out, that is when you tie it so that it doesn't come out. That's what I'm trying to say.
Okay, so this is for those in the communities.
Yes, please.
And do they have to do this if fetal heart is gone?
No, if the baby is there, but in cases of fetal demise, then we are managing it so that the cord is not occluded to prevent the blood flow from going to the baby being cut off. So if the baby is already gone, then there is no need to. The only way out now is to manage the woman and make sure she doesn't go into any complication.
Okay. So the slide before this one, let me see that one. And so if you are in a facility, what then happens?
If you are in a
facility that has theater and all that.
So if you are in a facility and the woman is fully dilated and then delivery is imminent, you deliver the woman per vaginum. Either you give assisted vaginal delivery, or if the woman is not fully dilated and delivery is not imminent, you have to relieve the pressure of the cord and prepare the woman for emergency cesarean section.
Okay, and so is the relieving the pressure on the cord, what does it entail? Is it about only the knee chest, or what do you do?
We do the knee chest, then we do transbalance bag position, and then you can also use your hand to push the head up.
So once you push the head up, and then you push the cord in, isn't it?
No, you don't have to handle the cord to avoid the
So
vasospasm.
the cord will be outside.
You cover the cord per the management that I know. You have to warm this thing.
Normal
a normal saline and cover with the gauze, you cover the cord. But you don't have to touch. Yes, you don't have to touch the cord.
Then it means that even with the bladder infiltration, we still don't have to touch the cord.
No, you have to avoid vasospasm at any cost. And mostly, even when the woman do the knee chest position, if the cord is not so outside of the introitus, it will slip back a little bit.
Please, we push the cord inside because there is no place warmer than inside.
Okay.
The vasospasm that we are talking about is allowing it in contact with cold and all that. That is why the vasospasm happens. And so you getting the normal saline, warm normal saline, there is nothing warmer than the vagina.
Sister, please, minimal handling of the cord.
So we are not saying you should handle it, what do I say, vigorously and all that, but you just have to gently push it in. And then you adapt that knee chest position so that it doesn't come out. Pressure is relieved off the cord. And then the cord is inside. It shouldn't be out. Once you push the thing inside and then you adapt the knee chest position, do you have to go and handle the cord again? Will you go and hold it again?
No, sister.
Oh, please.
Exactly. Because if you leave it there, okay, what happens when your warm normal saline that you put in gauze to put on dries up, becomes cold, still outside. Once it's outside, it has contact with the outside temperature and all that. And so we are not saying go and hold the thing inside or let it slip and then you are pushing it slips and you are pushing it. No. But once it slips and you push in, you adapt a position that you wouldn't see the cord again. That is where the knee chest and all that comes in. And that is when the bladder infiltration and all that. The bladder infiltration, if you don't push it in and then you do bladder infiltration, it is of no use. You do the bladder infiltration such that the bladder will be full, becomes an abdominal organ, and then compete with the head there so that it doesn't allow the head to descend. Just like when there is full bladder and then head is not descending. That is why you do the bladder infiltration. I hope this is clear.
Yes, sister.
Yeah.
Yes,
Sister.
And I still want to say, all right.
Thank you, sister.
Do we have any other question? And please, when you have some of these cases and you realize that the fetal heart is not there, do not rush for us to go and cut the woman and inflict double pain on them. Please. There are people who, when they come across cord prolapse, all they know is they say cord prolapse is an emergency, so they start screaming. You start screaming, Dr. Menya cord prolapse, so no dimekana or prepare. Say FH or say FH in honum. It only becomes an emergency when the FH is there and we want to save the baby. Then we are all rushing the woman through the process to be able to save the baby. But once the mother came in with IUFD and there is cord prolapse, please, if presentation is fine and then you know that this one can go through SVD, we shouldn't rush the woman to go and get a CS car or spoil the woman's obstetric history whilst she goes home with no baby. Please, I hope we understand. So when we will get the case, we understand, yes, it's a cord prolapse. Push the thing in. Make sure there is pressure off the cord. Now assess, let's see, is the baby okay? Is the baby alive? Okay, if the baby is there, then we know that this one, we have to rush the process and then get the baby out. But once we push in, block the cord, make sure the cord is not coming out again. And remember, when the mother is in knee chest position, you wouldn't be able to check your FH and all that. And so when the woman comes in, you put the woman in a knee chest position, infiltrate the bladder so that the cord doesn't come out again. And then you block, you can use a clamp to clamp the catheter. Once you clamp it and then the bladder is full with cord inside and everything inside, the mother can get back to the lithotomy position or get back to the supine position for you to be able to do your assessment, do your FH and all that. And here, the first thing that should come in mind is the FH. You know that every condition has its own priorities when you are doing clinical assessment. And so this one, what should come in mind is your FH first. So once you do FH and you know that FH is there, then there is no time to waste. And you don't also waste time with the bladder infiltration and all that. Once it's called prolapse, you know the next thing to do. I hope it makes sense to you.
Yes, sister.
Yes, sister.
Yes, sister.
Okay. Please, do we have any other question?
Sister, please, I want to ask if it is twin gestation and the other one is prolapse and there is no position. Do you have to relax and deliver the first one
No,
and
no, no,
then
no, 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 no,
or emergency?
no, no. For that one, we don't even have an excuse. We just have to go now. Udi maneda hono mchana ba kono so kwa na oyende.
But call is intact. The first one
And
that is
is it a mono or die? Have you
dies.
had such a case before?
We have it, but they all went for CS.
Yes, nobody will risk it. You get it?
Yes, sister.
Nobody will risk it. And besides, you know that when it comes to FH issues or cord prolapse, especially when they are coming from the house and then they come and like you are saying, twin gestation, one cord is out. We don't even know when the baby's FH went blank. We don't know when that IUFD happened. And you know the implication of keeping an IUFD in a uterus for a long time. So nobody will risk it. We won't let the woman go through and then at the end of the day go and get another wahala. We'll rush it. Once they are two, at least we can save one and then let her take her baby home. Temperature, don't risk it. Why?
Yes, sister. Thank you.
Please, I have a contribution.
Yes, please come in.
All right, I once had a case. So when the lady came, she was 36 weeks plus 2 days.
Okay.
When she came, she was like, Madam, something is coming. So I asked her to climb the bed, and then on examination, I saw the cord out. So I asked her when he said 3 days ago. She has been out in the house for 3 days ago. So on the third day that the husband brought her, she thought that her 9 months wasn't due, so she was waiting for the 9 months to come. So when I rushed her to the hospital, the FH wasn't there. She delivered, but the baby was gone. Was gone about 2 days ago.
This one will come and worry you with DIC, with some fucking bleeding and DIC. You haven't even encountered before, and then they end up coming to die in your hands, and then another thing altogether.
Yes, please.
So please, those at ANC, I think some of these things you have to strengthen your education and all that, so that we don't end up getting some of these things. Yes, I know that some of them are non-attendant. Yes, I admit that fact. But I mean, the ones that we get in contact with, even if it's one contact, let's try and then do our best so that we don't end up getting some of these cases. As I speak to you, a facility has recorded a mortality and it was IUFD for some days. IUFD for some days, and your colleague midwives kept this woman on the ward, checking FH and recording FH when the baby wasn't there. Now they keep this woman in the ward, saying that the woman is in labor. The woman slept there for some time, and then labor, like they are saying,
there was nothing speaking about labor. So they decided to transfer out to a different ward to sleep there. And that was when the in charge of that unit was able to tell that, no, this baby is not there. And then they had to induce. They did the induction, and then when the baby came, maceration. You know that kind of offensive maceration. And then when the baby came, bleeding, so the bleeding wasn't clotting one bit. So that's the risk of IUFDs. So please, let's be alert, okay? I think our time is up, so we will meet next week. Next week, you will do your medicine, so get ready. Have a good evening.
Good evening, sister. Thank you.
Right.
Your sister.
Bye.